So for the next couple of sessions, so this June session, I cannot believe it's June, and we will not meet in July because it's on July 3rd, and we felt like that was just not fair to anyone, and that most people will be somewhere off vacationing or at least taking some time off. And then we will come back in August. So for June and August, we're going to be focusing on considerations for CoCM vendors. So using vendors in different capacities to fulfill some of the mission or some of the uh, program requirements to have a CoCM program. So we've got one brave vendor that's going to talk to us today, Neuroflow, and we've got 3 or 4 the next session. But we were going to start today by having a conversation and just thinking through what are some of these considerations. So first, we're going to just ask some questions. We have got a poll. We're really a poll, really kind of just some questions with some open answered answers. So you can go to menti.com, menti.com, and put that code in there, 888-42793. Or you can use your camera and snap that QR code. And we've got 3 questions. One is, are you using a vendor? And if you don't want to do this, you can put it in the chat too. We just wanted to give people the option to have a little bit more anonymity. So are you using a vendor for delivery? Why or why not? So we've got no, we are not. No, built in the system. We've got someone who is using a vendor. You can also add maybe why or why not, things that you've got. So menti.com with the code.
And if you didn't get a chance to see the code, it's right at the top of the presentation as well.
888, yes, 888-42793. I'm going to try to do it and see if I can get it to work. Yay!
I used my QR code because I'm a QR code person.
Those cameras. So we've got a couple of yeses. Using CMTS. Anybody put things in the chat now? Hybrid for some markets. Okay. Yeah, that was one thing we had talked about is components, so pieces of things. Okay, we'll give everybody just a little bit more time to answer, and then we can move on to the next question. So the next question is, what are your experiences with vendors in CoCM? So if dissatisfaction, no experience, communication lacking. Next question, there we go. Cost prohibitive. No experience. Adult CLCM, like the ability for peds. Some concerns with sending self-report to kids and teens. The well-developed and precise, but harder to incorporate into the local culture. Good stuff here. Laura, does it have the ability to save this stuff? Do you get to keep these answers?
I will find out. If not, we have the recording. But
Oh,
this is
true.
all really great feedback, both capabilities and limitations that people are experiencing with vendors.
And one of the things that we hope to be able to do here is give a wide variety. So today we'll be talking with Neuroflow, and the next week we'll be talking with several others. And so, being able to kind of think through the different options. So the next one is, what would you like to learn about related to vendors? This is an opportunity to ask your questions, make sure that we're addressing the things you want to learn. Options for peds, not sure. Customization, so what resources can be customized for specific needs. Measurement options again. How they integrate into the clinic. Cost. So some feelings about things not being transparent, so not really knowing what things are going to cost. Do all vendors deliver fully remote, virtual care? Are the staff ever in person on site? Okay. Well, for the sake of time, I really appreciate everybody adding your thoughts. This is some really good stuff, and a few things that I don't think we really thought as much about. So I think it's great.
Absolutely. I'm going to get us back to our other slides. Give me 1 second. Yeah, so to break down some of the things that were highlighted today, when you're thinking about considerations for structuring CoCM components within your care system, a lot of these pieces that we brought up are going to be taken into consideration, especially with vendors. So the first being, what's your experience with CoCM? Some of the appeal to considering a vendor is you have this plug and play kind of option, or a packaged approach that is helpful, especially if you have limited experience. So think about your familiarity and comfort level with the clinical as well as administrative aspects of the care model. Other considerations are resources and logistics. How is your team planning on funding this care? What are the resources you have in terms of hiring and in terms of workforce? Some of the care components you want to consider are the need for a registry in addition to your electronic health system. They may be one and the same or two separate pieces. You want to think about documentation templates and how you're going to provide the care in terms of notes, billing and coding structure. And that's going to include state by state specific pieces, as well as, do you have familiarity or buy-in with your billing and coding team to provide this? That can be an advantage of using a vendor. What's the communication structure, preferences, and needs? Having an on-site in-house team, kind of like that last comment that we had on what are you interested in learning about, can be very desirable. There can be capabilities, but also limitations with some vendors in offering that. So what's the modality of communication? Do you want that to be in-house, or is it okay to have that remote? And then thinking about how are you going to go about consenting and enrolling your patients. Some vendors have that built into their processes. Others, you're going to still keep that in your care system. So how is that going to interface with that process? In terms of time and staffing, what is it looking like for dedicated staff for CoCM? And what's your workforce development pipeline with hiring as well as retention? And then think about the care system that you're delivering care. So is this a community organization or an FQHC? Are you mostly private pay, Medicaid, self-pay, or a mixture? And that similarly goes into state by state differences. And then the last part is think about needs and goals for your program. Where are you now and where do you want to get to? An example is if you're in an academic institution, that might be a different goal and need compared to a community-based program. So how does that mesh or not mesh with the vendor that you're considering? And what's your desirability as well as ability to deal with lack of autonomy or desire for autonomy? Do you want something you can tailor and make really specific for your mission and organization? Or are you wanting sort of a ready to go option, tried and true, that's structured for this type of care? When we think about technology components, that's a big piece that there's a lot of capabilities and opportunities with vendors. So we want to be thinking about what's the administration processes for measurement-based screeners. You'll hear from Neuroflow today, for instance, about how they use measurement-based screeners and processes to help facilitate care. Look at communication modalities. So is this going to be mostly in-person, hybrid, virtual? Are you going to want to have asynchronous, so okay to kind of wait a little bit, or do you want real-time communication? And then look at your electronic health record. What are the capabilities within as well as outside of that? Can you embed this technology, or does it need to be an external technology source? And what's the ability to communicate with the registry? Next, we're going to go here, and Monica, take it away.
Yeah, so we wanted to just provide, sometimes we've gotten questions around what should be in the registry. And again, there's no hard, fast, necessarily rule about what you have in your registry, other than you want to make sure that it is a tracking system, that it's live and not just a kind of once a month run report type situation. But you do want to make sure that it's tracking, it's functional. You're looking at measurement based because you have to do the treatment to target component. And so one of the resources that are free and available on our AIM Center website has to do with the registry. So whether or not you decide to use a vendor, build it your own, use a spreadsheet, collaborate with someone, it would be important to take into consideration some of the things that we have in this document, which will be in Basecamp for those of you who want to go back and look at it. But you want to make sure that you are tracking clinical outcomes using that population-based lens, that you're looking at engagement across the caseload with the patient. Again, the measurement-based treatment to target. Here it mentions PHQ-9. We're very much aware that people are using lots of different evidence-based, emphasis on evidence-based, tools of behavioral measures in order to track. So whatever measure you're using, just make sure that it is not just a screening tool, that it is actually used for follow-up as well. So that component of it. And then it'd be great if you're also able to have in your tracking or registry the systematic caseload review that happens with your psychiatrist. You, of course, want to monitor patients' individual progress. And then also in the document, it talks about some registry inclusion rules. This is just an example. Different organizations have different inclusion rules. So whatever yours are, you want to make sure that your registry is able to do that, that you're able to also look at the status of your patients. Sometimes we get very involved at enrolling the patients, but then we also forget about the importance of seeing the patients who are in relapse prevention plan. If you are a part of leadership, You are going to want to see information on the patients who have graduated or discharged. So you want to make sure that your registry and the information that you're putting in there has the opportunity to do all of those things. And then the last page talks about reports. And reports are not just for leadership. Reports are also very helpful for the behavioral health care managers who are doing the work. When I was doing that work, I was also a supervisor or leader of behavioral health care managers before I moved into C-suite. So it was important for me on that level as well. But an opportunity to actually see how the patients were doing, what the contact attempts were like. A lot of those things helped guide me to know, did I have behavioral health care managers that were maybe spending too much time? Let's have some conversation with them and think about the context of the patients they're seeing. Were there more complex patients? Did I maybe need to do some additional training on workflows, on that initial assessment? I remember doing that often. But there's a lot that if you go back and you look at and run some patient level reports, some caseload level reports, could help you if you're in a role of supervising behavioral health care managers, or if you're a behavioral health care manager, you should look at that because you're able to kind of see, how much time am I spending with the patients? Is it enough time? Is it not? Are the bulk of my patients improving? At what rate? How long are they staying in treatment? Because I want to be able, those patients who are doing well, to get them off of my caseload to allow more room for additional patients. So it's an opportunity to look at all of that. In some systems, they've also had interventions that are being provided to the patients on their registry. And from that standpoint, you're able to kind of tell, like, oh, majority of the patients are receiving this type of intervention. And just look at some of the trends that might be coming up for the patient population that you're working with. So this information, as I mentioned, will be in Basecamp for those of you who are interested in it. If you don't want to wait on us to post it in Basecamp, you can also go to the AIM Center website and grab that for yourself as well. All right. So we wanted to make sure to give an opportunity for our vendors to speak and an opportunity for those of you who are part of the CFHA community to ask questions and provide some, provide some insight also to those who are providing the vendor services, because things do change. I think there are sometimes individuals who try it on their own and they're like, this was a great heave ho and it is not working, we need to call someone. And one of the things that came up as we were asking about topics was around who is providing services to healthcare organizations that are wanting to implement collaborative care. So we started to reach out to different vendors, and as Tisha and Laura mentioned, today we have Neuroflow. We did have, it wasn't although I like y'all, Neuroflow, Matt, Damien, I like y'all. It was not that we were just trying to have Neuroflow present today. We actually had 3 presenters initially for today, and 2 that had some things come up and had to back out. So we are starting with, that could be the case, Matt. So we are starting with Neuroflow today, but then on August the 7th, we have 3 or 4 additional vendors that will also be speaking. And so I think this is just a good opportunity to see some of the great work and time that some organizations have put into helping healthcare systems, and an opportunity to ask questions. So today we have Matt and Damien, who are going to be talking to us about their organization, who they are, what they do, how they're helping us with collaborative care, and answer any questions that you all may have. So I turn it over to the 2 of you. You should have screen sharing capability if you need those.
Great, thank you. And thanks for the invite. I'm involved with CFHA in a couple of different things. So I'm in the health technology work group. So appreciate the work that everyone does here. So I'm Matt Miclette. I'm the VP of Clinical Operations for the team. So I'm kind of the clinical executive along with our CMO, Tom Zobler. Really, a couple quick, before I dig in, a couple quick maybe rhetorical questions, because there's not a lot of people on camera. Have you heard of Neuroflow? And if you have heard of Neuroflow, do you know what Neuroflow does? and maybe
Do you want individuals to come off camera and speak, Matt?
Sure, yeah. I mean, I would love if someone wants to start and take a stab at what we do.
Now, I will start and say, I had not heard about Neuroflow until last year, which is how Damon and I met at the CFHJ conference. And I have been, although I've only been with the AIM Centers for a year and a half, I've been doing collaborative care for quite some time. So I ended up going to a session at CFHA. I forget the young lady's name who was doing that session, but Damien was there. And that's how we connected. So I will say I was in the dark about Neuroflow.
Saw Patty come on screen. I'm like, I feel like you're cheating because we've talked so many times, but.
Oh,
Patty, we can't hear you.
You're off mute, but we still can't hear you.
Our computers.
Put it in the chat, Patty, because you know we
In
like
the
what you
chat,
gotta say.
I think Bree, if I'm saying that right, tell me if I'm saying it wrong. Bria says she's heard of them, but not sure what they offer.
Look, I've been working in Neuroflow for well over 5 years now, and I still have trouble sometimes explaining exactly what we do, right? Because it is a little bit more complex. We're not your standard vendor that you're probably going to talk to over the next few weeks. We're a technology company first, right? We are not a staffing company first. And that's kind of the big differentiator you'll probably see from us versus some of the other folks you're gonna talk with. I'm going to focus really heavy on the technology when I start flipping over and show you some images and not my face. But I want to make like one clarification, which is we do staffing. We just do staffing in a couple different ways. So one is we're just the technology and you guys are staffing it, right? That's how most of our deals work today. We could do it where we come in and support to help grow the model. So what this looks like is, I bring in a couple care managers as we're scaling up, right? And maybe we kind of plug and play them. But if your strategy is to really use a vendor, we work with a lot of the folks you're about to talk with as well, right? So behind the scenes, often Neuroflow's empowering that and their solutions. And what I'm getting at here is we're the experts in this space. So even if we're not the right fit for the staffing side, we'll direct you and figure out kind of the right way to go. So we're happy to be consultative. Our team, super experienced in collaborative care. My CMO and counterpart, Tom Zobler, was at the AIM Center before it was the AIM Center, along with Wayne Cannon and that team. So, we love this model and love to support it. But I'm going to start sharing my screen. So really, like, what the problem we were trying to solve for is we know CoCM works when it's delivered well and someone used the term fidelity, right? Fidelity to the model. But if it's not delivered well, then it doesn't scale and doesn't work. So that's really some of the problems that we were trying to solve for here. And can I just get a thumbs up? Can you guys see my screen?
Yep, looks good.
Great. All right, just making sure. So I'm going to walk through kind of at a high level today some of the ways we kind of support kind of that collaborative care workflow. And what I hope you kind of get out of this is our technology is really meant to be a behavioral health infrastructure where collaborative care is a core component of what we do, but not all of what we do. And we really want to think about this as population-based management rather than like caseload-based management. So these solutions are going to support not just people in collaborative care, but everyone that's kind of within that provider panel. So for example, when people come in, we're going to get them screened. Interesting fact, we capture the majority of the PHQs and GADs collected in the VA today. Close to 60% are being collected by our products. That is primarily through SMS text and being able to send that and capture that information. So it's not just an app. I think apps look better. That's why we show you pictures of them. But it's about how do we use email, apps, SMS, right? A tablet workflow in different ways so that we can engage people and collect that data. We talk a lot about measurement-based care. That's really where this fits in. So I'll double click in there. We also just talked about the registry, right? And meeting all those functional registry requirements. So all of those basic sort of things are going to be in there, right, around caseload reporting and the different types of tracking that you need, but also a lot of administrative support. So time tracking's in there. I can set reminders and filter different caseloads so I can find different people. We also, back to kind of fidelity to the model, wanted to figure out how do we start standardizing how collaborative care is delivered. We know it's really expensive to be using LCSWs and independently licensed folks to deliver this model. So what if we start designing pathways where it's much more standardized when I know what I'm doing, that second encounter with a patient with depression? So we've actually designed multiple different pathways where there's digital companion programs and therapist guides that help direct how the care is delivered throughout the program. And then finally, I think what's really unique about what we do, I'm really passionate about the suicide prevention, particularly in primary care. But we can continue to monitor patients after they leave the program. So our registry, again, back to like population-based management, our registry is not just for people in CoCM. We have different program statuses. So we can track people in CoCM, but when they leave, we can continue to remotely monitor them. And if there's an escalation or they exacerbate in their condition, we can proactively outreach, do a quick screen, see how they're doing, and potentially re-enroll them in the program. So this is really what I want to hit on today, is kind of some of these 4 points, just to give you kind of some insight into where we fit into these workflows. But I'm going to take a big breath because I know I'm from the Northeast, talk fast, all that stuff. Any questions so far before I double click? Great. So again, universal screening is a core component of collaborative care. Why it really becomes super important is we know provider referrals alone are not generating a lot of patients coming into programs. So I'm not sure if you guys have seen that with your own internal programs, but largely the talk on the street, right? And somebody can jump up and correct me if I'm wrong, but provider referrals alone lead to very few patients engaging in the program. So we're trying to think about how do we better identify patients at scale and think about these universal ways to identify patients. Everything we offer is modular. So people are just using this component and treating it as a triage tool where they don't even have collaborative care. But what they're doing is based on the outcomes, they're able to automatically generate referrals and resources based on the identified needs of the patients. So very, very responsively, let's think about social determinants of health, or I guess now it's social drivers of health. If I identify a housing security need or a food insecurity need, I can actually get sent back localized information about that based on the need. So someone mentioned customizability. That's where this plays in. We're the infrastructure, but everything can be configured in here to kind of meet how we would triage patients at your organization. And that would include triaging and finding folks to get into the collaborative care program. Want to take a big breath? Everyone with me? Cool. All right. So there's a number of, the name of the game to be successful as a technology company in 2024 is interoperability, right? We have to be able to exchange the data between the different systems in near real time. So that's really what a lot of our investments gone toward, right? Is how do we collect the data from all these different disparate sources? So we know BHCMs are going to have to collect some. We know that there's some that are living in the EHR. We know that we're collecting some remotely because we're using Neuroflow. So we have the bidirectional integrations where we're pulling all of that, all of the validated measures into the platform. So that way we know that BHCM's looking at a source of truth and then pushing it back out to the EHR so that that's living in the flow sheets for the PCPs. There's also a lot more we're doing around like generating encounter notes at the end of the month. That way, a lot of the documentation and things can happen in the registry. But you know, you've seen one EHR, you've seen one, right? So we're designing a lot of cool, unique workflows now that I can get into. So now that we identified folks, because we have this really cool universal screening protocol, we kind of have some cutoffs and guidelines for the types of patients we want to enroll in these programs. Now I'm going to bring them and change their program in our registry to collaborative care. Again, what's unique here is maybe instead I wanted to send them to our PCBH model that we also run, at the same time with our CoCM program. Great, you can do that too. You would just change the program to PCBH, right? So that's kind of how we're thinking about it, is not just monitoring outcomes of one program. How do we monitor the outcomes and track the outcomes of all the programs that we're starting to refer patients to? And we can drill down, but basically we can track the outcomes of anything. So, I'm a veteran, that's my background. So if we have enrollment files and know about veteran status, we can actually add information that allow us to run segmented reports on military veterans. I can also use that to trigger content on veteran resources at our health system, right? So all of that information can really be configured and changed. I got on a soapbox and lost my train of thought. So everyone's still okay, doing with me? Some good head nods, thank you. All right. The beauty is we're doing more and more, right? AI is the buzzword, but what we're really doing is risk stratification and thinking about how do we create new ways to look at risk. So we have a couple of what we call it internally our severity score. It's really a risk score. And now we're developing new what we call causal complexity scores. And what these basically do is look at risks of population. So not just looking at the PHQ-9 anymore, right? What are the other inputs and things that we need to be looking at? I'm not going to get too much into suicide prevention today, but we know our thoughts on suicide have drastically changed over the last few years in terms of what leads to suicide, what does a person look like, who completes suicide. We're incorporating some of that information around using those real-time measures to help with some of that risk stratification. So that's really where the power is going to come in here, is using that retrospective data that we're pulling from the EHR and powering that with the real-time data we're getting from patients. And again, all of the reporting, billing reports, the right billing codes, the number of minutes I spent with patients, all of those things are kind of downloadable by report in the platform itself, or we basically just hook up some pipes and have the reports feeding out wherever you want them. One vendor I hope speaks with y'all is EvolvedMD. They're a unique one because they are an in-person staffing company. They use us as their back end, and we're sending their data to somewhere else. So they're not actually running these reports. We have what's called Snowflake integrations where they're getting that data fed in where they need it. So reports available, but ultimately all of this depends on your workflow, right? What I'm really passionate about is I'm a nurse by background, and we believe in algorithms and standardizing how things are done. The rest of my team is all social workers, and they live in the nuance and the gray, which I totally appreciate. But we're trying to bring those two worlds together, right? So how can I feel confident that I have a new LSW, maybe in the future a BSW, right? Delivering this model and feel okay that they're going to do a good job. Well, we can know which modalities are best practice. We can lay out protocols for those best practices, and then we can train them in those modalities. That's what we're doing. So we're actually building out standardized programs where after you do that intake, you can start routing patients down different chutes. And basically the way we designed it is the first 3 months will be a standardized program, psychoeducation, very much CBT based for most of them. And then there's another offshoot in terms of what is the complexity. It could be depression complex by grief. It could be depression with chronic pain. So that's how we're making it feel personalized, but truly in the back, it's very standardized. And now, again, I can run the reports and look at people going down our depression track. What are their outcomes looking like compared to the people going down our anxiety track? The other issue with collaborative care in the past, and I'll get into this, is people who are not appropriate, right, are too severe. So we need to refer them out. What we're doing is we also have curriculums that are meant for triage. We call them triage journeys. So while we're finding you a resource, we're still giving you information, psychoeducation on bipolar disorder, what it means, right? Whatever condition it is that we're referring out for, still being able to support those patients as well while you're linking them up with care. Okay. Does this all make sense? why I'm passionate about it makes sense? Cool. All right.
I have one question, Matt.
Yeah, please.
Your digital companion, is that the therapist guide that you mentioned earlier?
So the digital companion is actually the app, right?
Okay, just that.
Again, that's web. There's other modalities, but there is a therapist guide associated with that program, so that the
Okay,
therapist has it to walk through different encounters.
gotcha.
The way we think about digital content is how we think about integrated care. It should be a stepped care model, right? So at the very bottom, and this is in all of our accounts and platforms, by the way, all this content, these foundational journeys at the bottom are really psychoeducation, right? They're going to come out once every few days. They're not meant to be treatment. They're meant to be some motivational interviewing techniques, maybe get them engaged in treatment, but it's education. The next level up is true evidence-based DCBT. So people who are resistant to care, right? Things like that, whatever reason, maybe they're waiting for treatment. We have DCBT programs. And then these guided journeys are what sits on top of that. So this is why we have a population tool that can work for everybody, because even if I'm doing quite well, I might benefit from positive psychology or some of this mood and sleep tracking and things that you can do. We have done a study, man, I can't believe some of the weights and some of the peer review stuff right now, but we did a study with a pain clinic looking at just the difference in those that engaged with the remote digital companion and those that did not. And bottom line is those that were engaged between the appointments, actually doing these programs, got better faster, right? And that makes sense because we already know there's research around people, if they do their homework, they get better faster, right? And then finally, we touched on this, but what's unique about what we're doing is we're generating alerts in real time back to people to respond to. That can both be suicide, like we read through every single journal entry. So if someone says, I'm going to kill myself right now, that will trigger an alert. We can also start establishing baselines for each patient. So if they're getting worse, there'll be a pulse in that score or an increase. So that basically will then send an alert to the care manager saying, hey, this patient's trending in the wrong direction, right? Maybe this is somebody we want to think about doing something different with. So that's, again, where some of that risk scoring is coming in, is how do we start automating and nudging folks when people need that outreach and help. So I'll stop there. I know I dumped a lot on you, but I will take questions, thoughts, compliments.
That was a lot, but it was a lot of good stuff. Okay, so first off, Matt, as a Army brat, thank you for your service and all the stuff that you're doing with the VA. I'm always super excited to hear that. And I guess I had a question while others are free to type in the chat or come off of mute if you're comfortable doing so. I guess one of the questions that I had is when there's an alert like for suicidal ideation, where is that going? Is that going to the clinic? Is that going, like if I were using Evolve MD or one of those behavioral health care managers, is it going there? Exactly where is or someone on your team, where is it going?
So right now I have a team that monitors for these alerts 365 days a year. So
Okay.
So if that, and literally we did this, by the way, I developed this program 5 years ago because people were scared to ask the PHQ-9 remotely. That's literally how it started getting formed. But now it's actually become a thing where, yes, we're actually responding to these in real time throughout the year. It can be brought internal, but we would love to manage it and do it really well. And we could talk through that. But again, that's my baby, is the suicide prevention aspect of things here.
Gotcha. Laura?
You know, one of the questions in the Menti was related to affordability and costs. Can you talk to us a little bit about how the affordability works, cost to care systems, you know, pricing?
Yeah, I think it's a really good question because technology is not cheap, right? Like if we're being blunt with it, like new technology, research and development, that stuff is expensive. So I'm not going to sit here and be like, hey, you're going to get, you know, the Neuroflow for the same price as the AIMS caseload tracker, because that's just not true. However, what we're doing kind of goes beyond just CoCM as well, right? It's really an infrastructure for like an enterprise. So I think for the we're ideal because we're not just helping with CoCM, we're identifying risk in the population. So anything that starts to become even slightly value-based, we're a really great solution for, and the mechanics just make sense. When you guys are fee for service, which I'm sure is the majority of you, because that's the majority of like the US, I think that's where we usually do our pricing based on looking at what are the expected revenue, right, outcomes, things like that, to make sure that we're all at least going to be set. The other, I know staffing vendors and things, right? They're going to come and again, I'm not trying to throw shade. I just know the vendors. They're going to say like 80% of a revenue cut to them. I think the benefits of working with someone like us, especially if you're doing internal stuff, is those implementation fees and things that you do. You own this technology once you have it, and you're building that infrastructure that you have for the long term. So that's our goal, is to really establish that infrastructure underneath. But yeah, I mean, if you're one or two clinics, that's probably not going to make sense for you. But if you're a health system, there's a lot of revenue opportunities. Answer your question in a very roundabout way.
I was wondering, I mean, can you talk a little bit about like the modularity? You said it was modular, so I'm just wondering kind of like how things could be broken up and used in a modular way.
Yeah. Can I just show you?
Yeah.
Let's see the actual thing. Hang on, let's log in it. Yeah, I mean, so when I first started at Neuroflow, it was just a measurement-based care tool for therapists. So then what we tried to do is build in ways for them to assign homework. And we knew that therapists wanted to be able to assign whatever they wanted because they're working with their patients, they're the experts. So we originally designed this as a platform that you can do whatever you want with, right, in terms of how the content's rolled out. So those core tenets still exist today. So if I come in, and this is our registry, but this is our content side of the house. If I come in here, we have, by the way, I showed you all the different journeys. We have a bunch that kind of come in, but let's say I want to do my own thing. So I want a CFHA journey. I could even design the art that I want to go into it. And then you're going to add the steps, right? When do you want them to start? And then the different activities under these. So you can literally build out your own programs here. And then what's magical is we learned that people also struggle with assigning these things that they built. So we also had to find a way to then trigger these things from happening. So that's where we created this concept of triggers. And just like I mentioned earlier with food insecurity, that was a trigger that I was actually describing. So when we do our SDOH questionnaire and someone marks yes, that's going to trigger a release of this referral. And that referral can be completely configured based on what we made. Right? So is that all kind of starting to connect? And then the last thing I'll show, and then I'll, I don't want to hijack time, but is we can actually configure different categories. So let's say substance use disorder, right? If I have this tag, I can run reports. I can automatically assign that content through a trigger. So someone has cocaine use disorder, I'm going to assign cocaine education content. And then third is, this is how we also help care managers, is if they have stuff like, hey, I need a referral I still have to make, they can use these tags and start flagging and finding patients later. So like, this is like one little feature that ends up kind of becoming really robust in terms of like opportunity. So that's kind of what I mean by configurable. All of that stuff can really be changed based on the program, resources, and kind of what you have on hand.
So there's a question around, where are your behavioral health care managers and your psychiatrists located?
So our biggest staffing use case is in New Jersey. So the bulk are in New Jersey right now, in terms of like being physically located. We are licensed in a number of states. Ascension's a great example. I don't know if I'm looking for any friendly names from Ascension here, but Ascension has different markets, right? So they have their Indiana market, they have their Tennessee market. Some of those are us and our staffing. Some of them are them. So I think that's what's kind of unique about us is they still have the same underlying infrastructure across the whole national enterprise, but we're kind of helping them stand up these programs where they need them. I don't know if that answered your question, but most of them are physically located, mostly on the East Coast, in Texas. It's care manager, but you know, the psychiatrist has to get licensed, and then we could talk about the clinical supervisors and everybody else.
Gotcha. Thanks, Matt.
Last thing too is usually we do consulting type stuff and as part of our deals, right? So like we want to come in, help design workflows, be part of the process, HEDIS measures, Prev 12, making sure that any sort of those quality measures we're able to collect. Back to like, how do you pay for this? You know, the CoCM billing codes are great, right? And incredibly helpful, but it's really all these other quality measures and things where we start to make this actually affordable and scalable. Great. I'm off my soapbox.
Any other questions?
Mine's not really a question. I find it fascinating. I wasn't aware of kind of how the different groups work together so much. So that's really interesting.
I feel like the whole CoCM community is very small. Like we're all at the very least frenemies, you know.
Playing nicely in the sandbox, as I
We
like
all
to
have the
say.
same goal
We're
here. We all have
trying.
the same goal.
We are trying. Matt, I'm wondering, do you have organizations that you work with who like they have a registry already built in their EHR, but then they still partner with you? And what does that look like?
Thank you for bringing that up because again, kind of comes back to being modular, right? So we're the infrastructure. So what pieces do you need? Emory is a great example. I love those. They're fantastic. And they built a really great homegrown designed Epic registry. They spent so much time on this thing. But they still were really struggling with the remote engagement side. They wanted that standardization, right? And all those other components. So we're still collecting all that data, and then we're just feeding it into the flow sheets. So it's loading into their Epic Bench registry. So 100%, it's kind of like, what components do you need? You don't need the whole kit and caboodle, right? What do you need for your workflows to make it successful? That's where we're going to come in and plug in. We can be end to end. We don't have to be.
And I will go back to the not survey, but the thing we did at the top, where people were making suggestions. There were some comments just around communication and kind of that piece of it. So how does that work outside of, yes, I can print my own reports?
Yeah, again, a lot of it's going to be through interoperability. If it's not coming, if we're talking about communication with PCPs, it's going to have to be, I assume, through the EHR, either a note or some sort of in-basket message or something like that. So that's a lot of what we've done is designed like different note types that actually get sent as either an inbox message or something along those lines. So that's a lot of how we try to improve like the efficiency between the communication. And that's regardless if it's us doing the staffing or not. And then also looking at doing, basically we produce end of month reports once everything's wrapped up for the month and you have all your billable time and minutes. When that pushes, then also having that encounter note getting created so that it can get reviewed and pushed off for billing. So that's a lot of, the types of things we're trying to do to make it more streamlined.
Perfect. Well, I don't see anyone else coming off of mute. Thank you, Damien. So Damien has put their contact information in the chat. If you all are comfortable with sending your presentation, Matt, then we will make sure to put that in Basecamp for individuals along with any other additional resources. Otherwise, we are trying to do much better with not ending at the hour so people have transition time. So thank you all for coming. Thank you, Matt and Damien, for your time and willingness.
Thank you. It's really helpful.
And and collaborative care, folks. Don't forget, conference for CFHA is in October. Hope you all are attending. Registration is getting ready to be open. Some of you should be responding back in terms of if you were selected to present, whether or not you are still available to do that. So just want to make sure everyone adheres to their timelines. And we're off next month, so have a great summer. We'll see you guys on August 7th.
Thanks.
Thank you for the invite, Monica. Bye-bye.
Absolutely.